Hello, exchangers of the gas. Welcome to the Gas Exchange Podcast, where we talk about respiratory critical care. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. This podcast is part of our efforts that inspire respiratory critical care, where we provide expert panel discussions, pearls, virtual classroom lectures, and other various initiatives. You can find our podcasts on YouTube, Spotify, and Apple Podcasts. On our website, www.inspire-rt.com, you can find links to our past recordings and many other resources. So down to business. My name is Keith Lamb. I'm the host. I'd like to welcome my co-host, Thomas Perino.
Hello.
And our very special guest today, Dr. Nick Ghionni.
Hello.
Welcome, Nick. Nick is a highly respected physician and critical care expert. We are fortunate to have Dr. Ghionni here with us today. Welcome, Nick. Can you tell us just a little bit about yourself, your background, where you practice, things like that?
Yeah, I'm Nick Ghionni. I am a pulmonary critical care physician, although mostly doing critical care right now in Virginia at Innova Fairfax, sort of like a bigger center in Northern Virginia. I did fellowship at MedStar Washington Hospital Center, and then before that, I was in Philadelphia for residency. I'm from Philadelphia originally. Moved to the like DC area for a fellowship. Um, Sort of stuck around afterwards because of like jobs and that kind of thing. And my kids are getting older and they have friends, and it gets sort of harder to move as you move on in life. But so yeah, now I sort of like you know, the name precedes me maybe, but I don't I educate online. As you guys might know, my fellowship is part of a larger conglomeration of fellowships that sort of do like specific mechanical ventilator education to attendings and fellows, like through a year-long course that's taught in like a specific way, and we sort of like teach it to like understand it and master it. um so I have been teaching for the course for like 2 or 3 years now. And as I mentioned before, I was sort of on like med Twitter doing some like education stuff, and how education has gone like recently in the past, I don't know, maybe 5, 8 years, sort of like getting out of societies and getting out of like journal publications specifically, and getting out of like the textbook and being more like real time. Um, and people getting it from all different places like podcasts and websites and Twitter and other social media platforms. Um, so I was on Med Twitter originally and sort of did a little bit of education stuff there, but mostly just followed people. And then Twitter became, Twitter, and things sort of fell apart there. So I thought to myself, like, what did I want to keep doing as far as like the medical education piece goes? So I was sort of like at a crossroads, honestly, probably maybe this year in like January, because I wasn't sure if I wanted to like keep doing that or what I wanted like my niche to be and stuff. I knew that I liked teaching the ventilator. Um, and I commented on you guys probably at least maybe heard of like Haney Malamet. He's a Cooper in DC.
Mhm.
He's the guy behind like Critical Care Now. It's like a pretty large online social media critical care podcast. Like they have a conference every year. And sort of by happenstance, I wound up talking to him, and we talked on the phone, and I sort of like told he trained at Maryland, so he was sort of like vaguely familiar with like the vent course, like as an idea. So he was just like, you should totally do this online. And I was like, I don't know. Like, who wants to listen to me about the ventilator? Like, sort of boring. And everyone has like different kind of like interactions with either RTs or the vent itself. Um, but he seemed to really think like this is an area that needs a lot of education and work, and people are always like wanting to learn that stuff. So I think like the first video I did on the vent was like last year. It was in January. And actually it was I don't know if you guys follow Critical Care Reviews. They're like a pretty big like platform for critical care review stuff, and it's like great. I think I can't remember who made it. He's in like New Zealand or Australia. But they actually put up a review of, I forget what it was, but they had waveforms on there, and the waveforms were like completely wrong. Like they had like straight flow. It was like square flow, but it wasn't like a straight. It wasn't like a linear rise in volume. So, which is like sort of like what we teach the fellows and residents. Like when we go through the event, we start with like the equation of motion and like work through the variables, and then they have to like draw out all the different waveforms like PC, VC, PRVC, pressure support, like and draw them. And so, if resistance goes up, what happens to the pressure? What happens to the flow and pressure control? Like that kind of stuff. So it's like really specific and nitty gritty. So I sort of did that first video and it like did pretty well. And I thought to myself, like, man, I guess people might care about this stuff. And then um another part of the course is just like taking pictures and or videos of vent screens and saying like this is a double trigger, this is a reverse trigger, like whatever. Um so I started doing that and putting it on Instagram and like polling people like, what do you guys think this is? How would you fix it? And then it just kind of grew from there. And then I got to talk with like other creators like Melody, who's Canadian, RT, who's like, she's also really, really good. She's been she was doing that even before I was. Um, but then we started doing more collab stuff and then it just seemed to take off. So now here we are.
Yeah, so it turns out that we have some mutual colleagues.
Yeah.
Yeah, and Dalton is one. He
Yep.
he's the one that sort of he's our VP of communications at Inspire,
Yeah.
and I should say that and I don't usually expand on this much, but on the podcast anyway. But I should say that Inspire is a all volunteer, all philanthropic. We've never
Yeah.
charged anybody for anything. As a matter of fact, we're going broke because we're paying. Tom and I are paying for
For all the
everything,
stuff. Yeah. I know. Tell me
and
about it.
so we have applied for our 501(c) or C3, and
Nice.
we're going to start soliciting. We're going to try to start getting grants and
Yeah.
donations and sponsorships, things just to pay for operational costs. That
Of
all being
course.
said, Dalton got in touch with you, our VP of communication, and that's how we sort of invited you to be on our podcast. We also it hadn't occurred to me until you just mentioned Inova again, but I used to work at Inova. I ran the ECMO program there for a couple of years,
Oh, really?
a while
Nice.
back, and pretty busy ECMO program. So you and I probably
Yeah.
know some of the intensivists there, Chris King, Mahul
Oh, yeah.
Desai.
Yeah,
Um,
Mahul's he went to Florida, but Chris is like my boss on the IHVI side. Who's
yeah,
Chris is great. Chris is like, I don't know, he's big into chess. Like he's on every committee. He's like
yeah.
master educator, like researcher. The guy is he's like who I see myself wanting to be one day. Sadly, in my whole sort of like soliloquy, I didn't mention that I do any research, which I don't do specifically, but I think, and because I know Tom has done a ton of stuff, and like, I mean, I was listening to your guys' podcast, like a few early ones, like the one you had. I don't think you had Burchard on here. You had Giacomo
Not yet.
Bellini on, I think, right?
Bellini,
Yeah,
yep.
yeah. And like I'm like, man, these guys are. This is like, like legit stuff. I think what social media slash like foam education, like free open access education, has taught me that for better or for worse, like anyone can be an educator. Um, you know, if you have people saying like not right stuff, that's not great. Purposely wanted to keep my focus like narrow in the vent because I felt like that's where I had the most expertise, and not like expertise like we just sort of I just made that up. Like I like through the vent course, which is how I know, like, Eric is at hospital center. So Eric is, one sort of like major pillar of the ventilator course that we do. And when you get done the course, if you take this sort of test and then they sort of bless you with your like fluent or not fluent with the mechanical ventilator, because the way that the founder of it, which is like Bert Lee, I don't know if you know
Mhm.
Burton,
Yep, Berkeley.
he's
Yep.
Bert Lee, yeah. So
Mhm.
the way that he thought about it was it's sort of like speaking another language, which I thought was which I think is 100% accurate. So he sort of graded you in fluency, like you're either fluent in the language or not fluent in the language. So I didn't want to sort of like be now, obviously, like I'm board in critical care, pulmonary internal medicine. So to some degree, I'm like expert in all of those things, but I feel like I don't know if I can talk from like really a point of authority with it. Whereas with the vent, I feel like I can, but it's not because I just like read Hess or something, right? Like we did this like very specific thing and sort of other people that are experts have said, you have expertise in this. So I wanted to
Mhm.
keep it like purposely narrow for that reason.
Yeah, so you mentioned Eric Kreiner, who is also part of our group. And basically, we all started out because we're just really close friends. We said, hey,
Yeah.
let's do it. About 2 years ago, we started to do a monthly panel discussion, and we'd
Yeah.
pick a
He
topic like,
he mentioned
yeah,
it before, I think, to me. Because was Burchard on one of the panel discussions before or no?
he's not been he's not been yet. He's
Okay.
we have him lined up to do a podcast, but
Nice.
he's not. Yeah, he's not been on a panel discussion
Got it.
yet. But anyway, so he's a close friend of ours, and he's our VP of science, and he.
I was trying to talk. Sorry, my microphone was muted. I was just like,
Oh, sorry. Go
Laurent's
ahead.
already sent us the papers he wants to talk about, so he is coming
Yeah.
on the podcast, but he just
Oh, of course.
he just hasn't booked a day yet.
Yeah.
Yeah.
Yeah, he seems pretty excited, and so are we. Obviously, we have such a
Yeah.
heavy hitter on the
So am I,
podcast.
honestly. So
Yeah, can't wait. So you mentioned Eric and his ventilator course. Um, we've talked a little bit about your social media presence, which is huge. Um, and um, and I think that Tom and I both agree that it seems like anybody can be an educator.
yeah.
But there's got to be some checks and balances, right? You have to
Right.
I always say, as a respiratory therapist, and of course most of our group are respiratory therapists, but I always say, as a respiratory therapist, you need to be the expert. You need to be the person that knows more about that ventilator than anybody else in that room. And if there's somebody in
Yep.
that room that knows more about that ventilator than you do, you need to work on that.
Yeah.
And we typically, at least in the United States, have a lot of autonomy when it comes. It's highly variable depending upon the center that
Sure.
you work at. But many times we have a lot of autonomy, and that's a good thing. But I always tell trainees that along with that autonomy, you have to be right about what you're
Right.
talking about, or you have to say, I don't know. Right?
Yeah.
You can't, you can't have a heavy stance on something that you are not sure of. And so
Right.
I think that is something that some online educators are not good at,
Right.
and especially today when AI. With I know you've seen this yourself on social media, on LinkedIn, on different platforms, where people are taking about 30 seconds to generate this really complex one pager about a specific topic
Oh yeah.
that that's not correct.
Yeah,
And
and
Yeah.
we're not knocking the use of AI. Like I'll have AI
no,
style something for me,
right,
but
Yeah.
the
Oh yeah.
if you don't understand the content, the output can be horrible and
Right.
confusing and misleading and
Yeah.
just back to your point, Keith, about, education, there can be a ton of education and sometimes not the greatest. A few years ago I did a reaction video with my friend Marco here in Canada. We did a reaction video to an online education video for mechanical ventilation geared at nurses, and it's my reaction to the video is legit. If you see it on my social media, you'll see I burst out laughing out loud, and it is not. It's like it was my first. It was a literal reaction video. We just started posting it. Like we just started watching it live, and then I took clips and put on social media. But anyways, they said you only need to understand two modes, and it said AC and SIMV, and I lost my shit. So
Yeah.
I'm like, so we
Well,
have to we have to acknowledge the fact that like not all education is equal, and unfortunately, there's also education geared at people who don't manage ventilators, and it can be extremely inaccurate. So when we think about this huge gap between understanding between like a respiratory therapist in North America and some other countries, the bedside nurse and the physician, the gaps can be like they're not all proportionate, right? So the gap in understanding between a physician and an RT might be this large or not at all. And then you have the
Yeah.
nursing where depending on where they're getting their education, the gap could be huge. And then we might think, oh, we're the RTs. It's okay if the nurses don't understand ventilation. It's like, yeah, but if all they're taught is that AC and SIMV are the modes, they start working somewhere. And of course, we're not using SIMV in the adult population. It might be confusing to them, right?
Mm-hmm. Yeah, you
Yeah.
mentioned you mentioned AC and SIMV a couple times now, Thomas, and which brings me to something that I heard recently, Nick, and that was that you're a huge proponent of volume targeted ventilation, like us,
Yeah.
like
Yeah.
we are.
So so like this speaks to like so many so many things. So my my sort of guiding light in this is that if if you can't explain this to anyone, then you don't know it well enough, right? And
Hmm.
I I get into I don't so part of the vent course, and like so I always go back to the vent course because that's sort of like where I draw my juju from, because as we pointed out, anyone can go on the internet and like say I am a vent expert, and I don't, maybe you are, right? Maybe you're not. Um, but I always preface it with like, this is what we teach our learners in this like very big ventilator course where we have like multiple people and like multiple like programs, fellowships, attendings, like I mean the whole kit and caboodle. So in America, and you guys know obviously, and probably everyone listening to this podcast, but you know, and I think in Canada too, when you graduate fellowship, let's say, right? I graduate home care fellowship. There's no one that says you are a ventilator expert now. Like go and do what you will, right? Same thing with RT school, I guess, where you
Hmm.
learn it, but like, do you get expertise? So that's a whole separate question. So what happens is I think you go into these silos, like these cultural silos, right? Like PRVC is the best. And I'm like, why do you think that? Like, oh, it's the lowest amount of pressure. I'm like, well, is it a volume mode? Is it a pressure mode? It's a volume mode. I'm like, are you sure about that? Like it says in the name, volume. I'm like, I know it's volume targeted, but like, is it a volume controlled mode? So, we're still there. Like we're still at that point. You have other centers like, let's say Cleveland Clinic, like with Eduardo, like teaching like sort of their taxonomy and like a similar sort of approach to the event, but like a little bit different than us, I think, in some ways. Then you have like Mayo Clinic, I think, has sort of like an approach to the ventilator. Um, but besides like those programs, like I don't know if anyone's teaching it in like a specific way where you ask these like very specific questions, like you understand like the physiology behind it. So, and people hide behind, I think, like the fact that it is complex, but if you can't explain it in simple terms and make it make sense, that doesn't like it doesn't help if you go on the internet and say, okay, you have an asthmatic on the ventilator, make the IDE 1 to 4, make sure there's no auto peep, or make zero peep, and we can argue about zero peep if you want. And then, like everything is fine and dandy. So like what I learned on Instagram is that there's like this, not only is there like residents and fellows and even attendings that need education, there's like all these other groups of people, paramedicine, pre-hospital, nurses, even RT. So like a large part of my follower base, which feels weird to say still, and I like because I feel like it's pejorative in some way, but that's just how we describe it. Are like respiratory therapists, nurses, paramedics, pre-hospital folks that are like managing the ventilator, and no one really taught them how to do it. So, it's not lost on me that people like message me and ask my opinion or say like, I learned so much from what you talk about, and my director says that PRVC is the best, and we sort of can go through like the multiple reasons why it's not the best, and like what does peak pressure really mean, and like does it matter if the peak pressure is like 20 versus 22? Like, what are the risks of using
Or
like volume
or
target,
60 for that
right?
matter. I can tell
Yeah,
people,
right.
saying an asthma
Or
patient, I don't care if my peak pressures are 60.
exactly, and
You need
well,
to understand.
so like, you know, so my literal first day on the job as an attending, we had like a very bad asthma patient on the ventilator, and they were on PRVC, and I was like, why don't we change it to volume control? And they said, we want the peak pressure to be low. And I was like, it's not really about the peak pressure. It's like about, making sure we don't kill them with the ventilator as we resolve their asthma exacerbation. So they're like, yeah, but the peaks now are like 24. And I'm like, they're 24 because she's breathing like very aggressively on top of all her auto PEEP, and she's about to like explode. So, at some point you sort of have to like just, and that's the other thing, right? So I'm some new guy. And I think if I asked you guys to sort of, if I plucked a random intensivist out of America or Canada for that matter and said, you have a very complex mechanical vent physiology, and I pluck an average intensivist out of the country and place them in that situation, do you think they'd be able to sort of handle that? I get the sense that your random intensivist might not be able to, right? We're so focused on not intubating patients with asthma because we're so uncomfortable with the mechanical ventilator in these situations. Now, does that make it right or wrong to not intubate them? I don't know, right? Like, I'm not sure. I feel like sometimes we, pull out all the stops to not intubate the patient. Maybe it's safer to just intubate them before they're like at death's doorstep. And then when you go to do it, they have a cardiac arrest. A topic for another time. But I think the fact that there is no sort of like standardized way of assessing if anyone, intensivist, resident fellow, RT, whoever, really understands the vent physiology. And then you get these things like SIMV is good for weaning. What is weaning? Like, I still haven't figured that out, right? We haven't weaned people since 1999. We don't like wean the ventilator anymore, but that's still like in our lexicon, right? So there's like multiple things that I think need to be addressed that I sort of address on a daily basis. And I get multiple, like, I mean, not like hate mail, but I'll get like messages like, what, SIMV, like SIMV is great because whatever. And I'm like, but the patient's paralyzed. So they're just on whatever your control mode is. Like, it's like, it's so many layers of misunderstanding with the ventilator that, and there's so many ways that things can go wrong because someone could just insert themselves, especially, and this is the worst, and I'll go on record, if they're a physician, because when you're a physician, you can get away with like so much as far as like claiming expertise. And then sadly, if I find the video, I'll ask like a very simple question, like, please explain pressure control. And then like the whole house of cards falls apart.
Yeah, I think you just very well articulated why we're here, right? I mean,
Yeah.
why we're here because we hear people talk. We recognize that there's a gap in understanding and perception of what's really happening. I love that you just said what is weaning, because weaning, in the way I teach it, weaning means you incrementally decrease something,
Right.
whether or not
Exactly.
it's mother's milk or if it's mechanical ventilation. You're taking something slowly, you're taking something away. Whereas for at least 20 years now,
Yeah.
we have known that that's not the approach, and that's why we don't use SIMV.
Yeah.
Many people get away with using SIMV in places like a PACU or a post-heart unit, where
Yeah.
somebody's intubated for just a handful of hours and they haven't had time to hurt somebody with the mode of ventilation. They
Yeah.
they sort
Yeah.
of have
Yeah.
an algorithmic, protocolized extubation where just everybody gets extubated in 4, 5, 6 hours. And I'm not saying that's a good excuse for continuing to use SIMV, but I think that's why, when you hear somebody really, really advocate for the use of SIMV, I feel like most of those people work in a heart center.
Or a
My,
pediatric center.
Yeah, yeah,
yeah,
yeah.
They still use a lot
and
in
that,
peds.
yeah. And that's actually come up a few times in the past year because some PICU docs will message me and say, oh, like we still use SIMV in peds. And I was like, oh, maybe there's like data I didn't know about. I mean, I'm not a pediatric intensivist. So I don't know. And some of them tell me that there really isn't. It's just more like of a cultural sort of like
Mhm.
norm to use SIMV and for whatever reason. But there was one specific time where there's a patient who we were, they were on an SBT or, you know, we were walking around with RT and I saw the patient on pressure support. They were on like maybe 10/5 or 12/5. It was like more, it was like a higher amount of pressure support because
And
they
they said
sort
they
of did.
were on a SBT. Let me guess.
I mean, so that's an interesting question, like, which I posed like probably in June of last year. Like, is that an SBT or not? Right? Like, are they like what? So what are these definitions of like SBT versus not SBT versus weaning versus like what does SBT really mean? And thankfully, I don't know if you guys listened to, like, Tobin was on a podcast recently with Critical Care Scenarios, who are a group of PAs, Brian and Brandon, who are actually like really knowledgeable, like with the ventilator. But Tobin was on there talking about SBTs, and so he's, I don't know if you've ever listened to Tobin sort of talk, but he's sort of like, kind of like cantankerous in
He's
some
like,
way,
he's
which I
Shakespeare.
love. Huh?
He's like Shakespeare.
Yeah. He's just like this sort of cantankerous guy that, has like done all these studies, and like just it comes down to like nothing matters, right? It doesn't matter. It's irrelevant what you call it type deal. But I think, and the thing that I've been fighting back more like recently in reality is like the RISB, right? So the RSBI score. So I'll walk around and say, the RT will say, the RSBI is good, we can extubate. And I'll, if I have some time, I'll say, are you sure? Like, is that what that means? Is that what Tobin said it meant? Is that what did Tobin have these patients on 5/5 when he did the RSBI score?
Nope.
So there's all these things that get sort of
No
like
ventilator
baked,
involved.
and no ventilator involved. Exactly, right? So which is interestingly what he thinks we should do for spontaneous breathing trials is all T-piece, which, is a separate issue.
That's what we do in Toronto. It's that every
Yeah.
hospital in Toronto does 0 and 0 on the ventilator rather than T-piece, but still zero support.
Exactly, because he has a lot of thoughts on it, which are obviously founded because it's Tobin. But my point is that all these things get baked into this lexicon that we have as like this like collective consciousness of the vent. And when you challenge that, people get very upset, very, very upset, especially people that have thought this whole time that SIMV is like is the mode that you should be using for transport or something, right? Like, there's this whole like subculture of transport medicine that I didn't know about until I started interacting on social media.
Yeah, lots of stuff unpacked there. Don't even so I have recently come across a group of folks at a smaller hospital that will say that if you're on pressure support, you are on, regardless of the level of support, that you are on a spontaneous breathing trial, and that's the way that it is documented. And geez, I don't know, even the RSBI, I don't know how many times, if I had a nickel for every time I had to explain that Tobin's data was accumulated by taking the patient off the ventilator, using a right spirometer, counting the respiratory rate, counting the minute volume, dividing that minute volume by the rate. That's the RSBI, and that's where that number 105 comes from.
Yeah.
I could retire, and but people
that was just to figure out if they could start to wean, not even extubate. Like, can we start this weaning process over a week or whatever, right? So it's just, I don't know. I mean, I think maybe it's a problem because we have servo use like the McKay, so it shows you the RSBI score like on the screen, and so I don't know if it's just easy to
it would be nice if there were conditions that had to be met before that value even displayed anything,
right.
Just like plateau pressure on that ventilator, if you don't have an inspiratory pause, it's just 3 asterisks, right? It doesn't show you a plateau. If you put them in volume assist control with a pause, then it's in real time all the time. I feel like the RSBI is one of those things that it should only show up if you have reduced pressure either to 0 or if Maquet wants to make it a little bit more moderate and allow like 5 centimeters of water. But when it's displaying, when you have a pressure support of like 18, it's like not useful at all. It doesn't.
And they say, "Oh, look, the RSBI is 30."
If it's high, it helps. I mean, I guess if it's high, it helps. It tells you that 18, this patient's not ready for breathing, essentially. But it's a misuse of the measurement, essentially. It still will tell you your patient's not tolerating whatever they're on, but it's not.
If they're failing 5/5, I'll just. And the RISB is like 150 or something, and RT is like, well, I guess we come back tomorrow. I'll just make the pressure report like 20, and then it'll be, like 50, and I'll say, so okay, extubate them now. The Risby is good, right? It's under 100.
Right.
So you sort of like, it's not, you have to like point those things out, which I don't know, like at what level it's a failure. Is it like a failure of the intensivist to sort of like of teaching, or is it a failure of like the schools for not sort of like specifically teaching like what each scenario was? Like the RSBI score was it was like a T piece, and it was like to see if the patient could wean from the ventilator, to start weaning. It had nothing to do with extubation. And he gets like particularly pissed about that, Tobin does, which I think is hilarious. That, I don't know if you guys saw it. There was I think in like 2022, he went back and forth in chess with someone that put out like a meta-analysis about RSBI score. And Tobin was like he was like super defensive about like that we use it for extubation. It was like never meant to be an extubation measure. It was just for weaning, but we don't even wean anymore. So then why do you even tell me what the Risby is? Like, I don't,
Mhm.
it's irrelevant what I extubated a guy yesterday. His Risby was 200 because I thought the tube was bothering him. So I just pulled it out and he's fine.
Yeah,
So,
yeah.
like,
Yeah, I've always taught. So again, lots of little nuggets in there, but I always taught that it's not important. In my practice and the way I teach it, it's not important what the RSBI is. It's important why the RSBI is what it is, no
yeah,
matter whether or not it's high or even. So you can have. I explained to somebody that your tidal volume can be a liter, and you're breathing 1 times a minute. Is that a pretty low RSBI? Would I extubate somebody who's breathing once a minute? No.
We used it more as a red flag as to whether or not you should monitor the first 5 minutes of an SBT, essentially. So you would do, and for us, because we were using 0 on 0 on the ventilator, that is also the RSBI. So we would just start them. We would look at the RSBI after 2 minutes. If it was greater than 105, we would continue to monitor closely for the next 5 to 10 minutes, just because if it's already 200 on 0 on 0, they're probably going to fail the
Right.
SBT, right? So you have to make a decision, like you just said, Nick. Like if you think it's something else causing this failure, if they're failing an RSBI and your SBT method is the same as the RSBI, chances are, like, if you don't monitor closely, they're probably going to continue to fail. So it was more of a red flag that's like, let's continue to monitor. But if it was good, then we leave them on this SBT. We essentially leave them on the RSBI settings, which were 0 and 0. We would leave them for up to an hour and then extubate them. As long as they made it 30 minutes, we probably would extubate anyways. But having said that, if it's a low number, we were comfortable walking away and coming back later. If it's a high number,
approach.
We monitor. Yeah. Again, it was just more of like a careful, this patient's not doing well already. Let's just monitor a little closely, because some patients will settle out after a few minutes. If you make that decision within 1 minute, if you make that decision in 1 minute and just cancel the the SBT, then you're probably going to miss a lot of potential extubations if you are following strict criteria for that.
Right. And that these both situations are like more nuanced. I mean, I think extubating is much harder than intubating, right? Like extubating, especially the patient in the ICU that like had a big pneumonia and now they're delirious or they've been paralyzed or prone or whatever it is, like that, like those calls are much more difficult to make because, and Tobin said this, like we're trying to sort of figure out if the patient's going to do well without the tube. And I think the crux of his argument is like, it's almost impossible to figure that out. Like, we just don't know if they're going to, like, what's the pretest prop that they're going to pass this SVT and then do okay when we pull the tube out, with so many things like that are factored into it, whether it's like their volume status, they're already have lung disease, like whatever it is. So, and what you talk about, or the way that you talk about it, Tom, it's like, that's much more of a nuanced sort of like approach, and not just like slap this guy on 5 or 5. Oh, he's breathing 30. The RSBI is 120. Up, it's a fail. See you tomorrow. I hope it goes better tomorrow. Um, you know, it's like a much more nuanced approach to it, which I think is what you need, especially when it's not clear. If you have a cardiac surgery patient, they're probably going to be fine, right? They're on Simv. Doesn't matter what settings you have. They didn't go in with lung disease. They didn't come out with lung disease. If anything, it's better. You pop them on SBT, they look good. You pull the tube out, end the story. Some people get, blood gases to sort of like make sure, and that's a whole separate issue, I guess. Or whatever the protocol is for that matter. But in the MICU with these respiratory patients, like it's hard to predict. I mean, I just don't know, right? I had the guy that I extubated a few days ago, he had like a long ventilator course, like, almost 2 weeks. He was breathing like 35, pulling volumes of like 400. I asked him to take a big breath in. He took like 1100 mLs. He looked okay. He's like awake, alert, following commands, was pretty strong, lift his head up. And I was like, I don't know. I think we should give him a shot. I pulled the tube out and he was like, fine. It was, he was like, okay. Like nasal cannula, not in distress, like just completely fine. I mean, how am I supposed to sort of gauge that at the bedside? Um, and that's like a lot of nuance. And I think your average practitioner is going to be uncomfortable with that maybe because of things they've been taught, whether it's like a respiratory rate more than X or an RSBI more than whatever. And then they see that, and then those are like sort of automatic no's. And maybe that's fine. Maybe, RT comes to me and says, listen, their RSBI is X, they're breathing 35. I don't feel comfortable, but you can take a look and see what you think. I go there and I take a look at him and the data, and I'm like, you know what? I don't know. Given like all of this stuff in totality, like it just becomes a risk of reintubation. Is this risk 5% or 95%? And you have to weigh those risk benefits. Is it like, am I willing to accept a risk of 60% of reintubation, give him a shot? That's sort of like a clinical call, I think, at the bedside. Me personally, I roll the dice most of the time and just pull the tube out and see what happens. Unless it's like obvious, right? If it's like an obvious fail, then I won't do it. But
Yeah, I think you're right, Nick. I think nuance really plays a big role in probably most patients. And like our friend Eric, and we always talk about on our panel discussions, you have to look at the patient that's in front of you. You have to individualize your approach and your plan based on the patient in front of you. And we don't have enough time to get into this on this one. We'd love to have you come back and talk more about how you individualize your care too. I mean, we know that we don't use SIMB. Tom and I have talked many times about we don't use volume targeted ventilation in an ICU patient and why.
Oh, I do.
Well,
when they're passive.
Yeah,
when passive, I've mentioned many times on the podcast and on the meetings that in a passive patient, I personally prefer volume assist control simply to set the pause in real time, and I use flows of 60 liters per minute, which is 1 liter per second. So I can walk by a vent and see their resistive pressure, and that's actually their resistance if you were to take those numbers and calculate it. And I actually see their plateau pressure. I know their driving pressure, assuming I've already measured or checked for auto PEEP, etc. But the minute someone's passive, I don't think volume targeted ventilation should be utilized, because you run the risk in volume control of flow hunger and in PRVC of pressure starvation. Essentially, like the ventilator will stop giving. Most ventilators will go down to a minimum pressure of 3, and you got the patient doing all of the work when if they're not ready to do. If they look great, sure, then you should just extubate them. But can't tell you how many times I got paged to the bedside, and by the time I got there, they resedated the patient because they looked horrible, and all I wanted to do was get there and switch them to a pressure targeted mode rather than PRVC. And then I get there and they're sedated, and I'm just like, can you turn that off, please? I'll stand here and I'll wait, and when they wake up, I'll put them on a pressure mode, like whether it's pressure control if they're not fully ready, or usually it's pressure support.
Yeah, what my stance is, and of course I agree. It doesn't really matter what mode of ventilation you're on.
Yeah, when you're passive, it doesn't really matter.
Yeah, but I certainly wouldn't use it on a sick ICU patient that's not passive.
No, if they're not passive, I wouldn't either.
Yeah.
Unfortunately, the very majority, I think, in America for sure, like PRVC is like been more of a go-to mode. And honestly, I didn't see any PRVC until I was like moonlighting as a fellow in other hospitals within the same system. And then when I became an attending, it's like all they use is PRVC, because we never used PRVC in at hospital center. Obviously, like with Eric running around, doing his thing, we either used pressure control or volume control. So I made a whole Instagram account based on the fact that PRVC is like the worst mode of ventilation. I mean, I've shown people be tortured. I've shown like auto PEEP out the wazoo. Just multiple like desynchronies just left and right. And unfortunately, some people like stand by it because of this like lowest pressure situation.
Mm-hmm.
And I've explained I've explained it up, down, left, and right, from multiple angles to multiple people in multiple countries. that like it's not a great mode for the acutely ill patient. And that, I guess, as Tom pointed out, sure, if you have, and so some nursing homes around us, like LTACs, they'll only take patients on PRVC because I mean, I think sort of what it's still incorrect, which is that it's the lowest pressure, which is not right. It's wrong because it's sort of irrelevant. Like it's not going to matter pressure wise.
Yeah, it's low peak
From the-
pressure, but if volumes are the same, plateau is the same, right? And we all
Right. So
understand that, but
so it should be the same. So, but like the specific LTAC wants them on either SIMV, which like that, you know, it's all right, it's bad, it doesn't matter, whatever, or PRVC. So they're the only reasons why we would use that. But as soon as they get into the hospital, we should be switching it to something that, you know, it's, I don't know if it's like we should be switching it to X or Y, like PC, PS, or VC. What you should do, as you point out, is like, what's the patient intubated for? If they're intubated for pneumonia and you think they're slipping into ARDS and they have a tremendous drive to breathe, then maybe they shouldn't be on something that gives them unlimited tidal volume based on their effort, right? Maybe they shouldn't be on pressure control because they're going to pull 800 mLs and that's going to lead to a whole host of issues. If they're intubated because they have renal failure and they have like a tremendous acidosis, don't put them on PRVC because that's going to, or volume control, it's going to limit their volume when, you know, what we need to do is like not so much fit the patient to the vent, but try to like fit the vent to the patient and their pathology. So yes, them taking big breaths fast is not good, but it's not anything we can fix with like sedation or like making the vent any better. Like we could just make it as good as we can as we fix the underlying condition. Back to Tom's point, you know, in the vent course, um, the one way to fail it sort of immediately is to suggest the fix be sedation. So Eric, like, we'll go over a thing and say, okay, who just wants to sedate the patient? And then in the beginning part of it, like we'll like raise our hand, and then Eric sort of points out that, you know, we shouldn't be using drug to fix a vent issue. Like we should be fixing the vent, and then so then, you know, if we fix the vent enough, um, and we can't do any more, the patient's still doing whatever they're doing. You have to make a decision at that point. Is it, you know, if this is unsafe for whatever reason, the volumes are too big, they got a bunch of auto peep, there's too much desynchrony, and you think that's hurting them, whatever it is, then as a last resort, you're going to sedate the patient or paralyze them until you can fix their underlying issue. And then once that issue is fixed, you should allow them to sort of breathe on their own in whatever way you think that is appropriate. Pressure support, pressure control, whatever it is.
Yep, I think that we both would agree with everything you just said there. It's about time to wrap this up. And Nick, did you want any parting shots? Did you want to tell us more about your social media? Point us to your websites, your platforms.
Yeah, so it's all at Home Toilet. But it's obviously like play on words.
I just wanted to hear you say that.
Yeah. Which been my handle for it's been my handle for a while, since Twitter days. Mostly on Instagram, TikTok, yes, but I sort of rarely post on there. It's a different atmosphere on TikTok. YouTube, same, which I upload stuff there sort of in spurts. I also started a podcast that I try to update at least semi-monthly, which is called the Peak Inspiration Podcast. What else? I guess those are and you could find that on like Spotify, YouTube, Apple. It's hard to do. So the podcast itself, I was sort of like wanted to take topics and go through them. It's hard to do that in audio form only because it's like hard to describe. Okay, the plateau is 30 and we're going to drop the volume and look what the pressure does. Like you have to see it. So even though I have it on Apple, it's not as kind of like, I don't think it's as sort of user friendly. It's more user friendly on Spotify or YouTube because there's video as well. So I try to post there sort of like with some amount of regularity. And I think those are mostly it. The other thing that was sort of my guiding light in this was I try to answer like every DM I get about the ventilator. And to be honest, and I think you guys are going to be surprised who is going to start to follow you. I mean, like Melody and myself, we've had followers from like multiple countries, but also multiple disciplines. So like one big underrepresented area in all this is like veterinary medicine. So veterinary medicine, they also have dogs with like ARDS. And they do like PEEP titration studies, and they use esophageal balloons and use like EIT, and they use all this stuff. It's actually pretty interesting. So
those guys are really smart. Those veterinarians,
they're super smart, and they really know their physiology like very, very well. It's like it's sometimes it's intimidating because they'll message me this like incredibly complex topic, and I'll give my like very mundane thoughts, and they'll say like, "That was brilliant, thank you so much." I'm like, I don't know, the way you just asked that question is like way more intense than I would have ever been able to like word it. So it's an interesting world, like specifically with mechanical ventilator education. Whenever I run APRV, I still call Eric to go over my settings with him. Like, Eric, what do you think about my settings on APRV? And he'll sort of like say, yeah, nay. And he, tries to like sort of not tell me I'm wrong, but he's, Eric is great. I can't understate how much he's taught me in 3 years. Like, imagine being in COVID with all like 30 patients prone, paralyzed, with tremendous lung physiology issues, and like Eric is there, drawing stuff on the whiteboard, going over things. It was something else. So
yeah, we had to
that's
fend
all
for ourselves, unfortunately.
Yeah, I know you didn't have Eric sort of there. So
right.
Thank you.
That's a wrap. Thanks, Nick, for sharing your incredible insight and expertise. Thanks to the listeners for joining, and please share and join us for next week's episode. A new episode dropped every Monday. And remember to visit our website to links for our podcast, panel discussions, and other resources, www.inspirert.com.